thank you guys all for coming. The reason why I have this perpetual smile on my face is because I no longer have to worry about being deployed. And I'm getting a paycheck every month, so life is good. And I know, right? And I have this great gig where I travel around the country and I meet great colleagues every week. So, you know, life is good. I'm very, very happy. So my talk this evening is on catheter-related thrombosis, a catalyst of complications. And you know, this is a topic that has really interested me for quite a few years now. And I'm really happy to see that in my travels, more of my nursing colleagues, more of my physician colleagues, the MPs, the PAs, we're really starting to become much more in tune to thrombosis, catheter-related venous thrombosis. So, financial disclosure, yes, I am an employee of AngioDynamics. It is a little chilly in here, eh? Oh, so this citizenship thing is, you could never tell by my accent, but I was born and raised in England, have kind of lived all over the world. So by taking speech lessons to learn different languages is how I lost my accent. So I just call myself, you know, a child of the world. Wherever I live is home. As long as you have your family, life is good. That's the way I feel, yeah. All right, so our objectives for this evening: identify the prevalence and relevance of catheter-related occlusions, define venous thrombosis, identify risk factors associated with venous thrombosis, discuss the link between PICS and thrombosis. We're also going to review the clinical significance of PIC-related DVT and identify management and prevention strategies for upper extremity DVT. So let's talk first a bit about catheter-related thrombotic occlusions. So, you know, the most common non-infectious complication in the long-term use of central venous catheters, and in particular PICS, are occlusions. Approximately 1 in 4 central venous catheters may become occluded. That's 25%. That's a pretty big number, right? And I'm sure that you guys in your daily work lives, you come across a lot of these lines that you may have to deal with, no? So, approximately 1 in 4 CVCs may become occluded. There are 3 types of occlusions. There's biological, mechanical, and physical. So, how do we determine an occlusion? What are the potential indicators of a catheter occlusion? Well, it says here, inability to infuse fluids, lack of free-flowing blood return, increased resistance when flushing, sluggish flow, and how about that alarm, those frequent infusion pump alarms? The different occlusion types. We have non-thrombotic and we have thrombotic occlusions. Our non-thrombotic occlusions, the lipid or chemical aggregates, precipitate the kinked catheters. Our thrombotic occlusions, the biologic, blood-related. We can have intraluminal thrombus and extraluminal. And that extraluminal, pardon me, you know, consists of fibrin sheath or that mural thrombus. And so that fibrin accumulation can initiate inside of the catheter tip, and it is often the result of blood reflux back up into that catheter tip that starts that whole process going. So how about the role of fibrin sheaths in venous thrombosis? So the development of a sheath usually begins with endothelial injuries such as surgery, IV, central venous catheter insertions. We have localized thrombus, which is followed by a depositing of plasma proteins along that catheter wall. All catheters will develop fibrin upon insertion. but we will develop fibrin at different rates and ratios. Fibrin can form in patchy areas along the surface of that catheter, or it can form in one long continuous layer. And I bet you guys have seen when you've pulled out some of the pics, the long stringy, that sheath that's come out with it, right? So it says here, the presence of a fibrin sheath alone may not be sufficient to cause either a venous thrombosis or a bloodstream infection, but may serve as the foundation for that. I think one thing that's important that we always have to think about too, and that was a learning curve for me too, the economics of an occlusion. Because there are really some significant dollars that are impacted, that are spent when we have occlusions. The cost of an emergency room visit, even a readmission. How about a cost of a catheter exchange? What is RN's salary? That hour or so that it takes to deal with that $35 to $50-ish range. How about the dose of TPA? So really, what is the cost of the inefficient delivery of IV therapy? There's a significant cost, not only in money, but in time. Our time and our patient's time as well. And how about on that outpatient setting? Chair time is a huge issue for any of you guys that out there in that outpatient infusion setting. Chair time means a lot. So there are some good articles out there, a lot more being published. And this was an article published in the American Journal of Infection Control, TPA. And I have copies of these articles. If anybody wants them, you can shoot me an email, boom, get it right off to you. But interestingly, they looked at 3,723 patients with PICS. 40% received TPA. The adjusted odds of developing a central line associated bloodstream infection was 3.59 times greater than those patients, in those patients that received TPA, in those patients that did not. So there is that positive correlation between the use of alteplase for malfunctioning catheters and the development of central line associated bloodstream infection. So let's touch on our catheter-related venous thrombosis. So what is a venous thrombosis? A blood clot that forms within the vein. Thrombosis is a term used for blood clot occurring inside a blood vessel. And a common type of venous thrombosis is a DVT, a deep vein thrombosis. And so, there are really a lot of terms now being thrown around. We call them upper extremity DVT, we call them DVT, we call them CRT, catheter-related thrombosis. And so you'll kind of see some of the terms being used interchangeably. And I don't think we as a community have really come to a consensus of how are we really going to define this. So VTE, venous thromboembolism, a condition that includes both deep vein thrombosis and pulmonary embolism. DVT, deep vein thrombosis. And then we have upper extremity DVT, the deep vein thrombosis occurring in the upper extremities. And are you guys becoming more in tune to this in your daily work lives in the hospital, and kind of you have that radar out for this type of issue that is now really come to the forefront? Diagnosing an upper extremity DVT. So look at the incident rates and going through the literature. The symptomatic PIC-related DVTs incident rate of 3 to 20%. Asymptomatic and symptomatic PIC-related DVTs, 60 to 72% incident. And you know, it doesn't really take long at all for one of these to develop. The median time to thrombus development, 8 to 12 days. Not a long time at all, right? Yeah. And then how about the financial impact of one DVT? Roughly $10,000 to $15,000. Hospitals are spending quite a bit of money on the treatment of this issue. Risk factors associated with catheter-related upper extremity DVT. There are 28 of them. History of a DVT. So a history of a venous thrombosis was actually the strongest risk factor for developing a PICC-related thrombosis. Catheter tip placement. Correct positioning significantly lowered the risk for developing a catheter-related thrombosis. And we all understand and realize now, right, that non-central PICC tip location greatly increases the risk. Infection, catheter-related thrombosis and infection are significantly correlated in a lot of studies out there. So we have really made that link, that correlation, that connection between thrombosis and infection. How about this cancer? The presence of cancer and a central venous catheter increases the risk of an upper extremity DVT 18-fold. Phenomenal number, right? Yeah. I was actually, pardon me?
Why is that?
Yep, they're more that's it. They're more hypercoagulable.
Does it depend on what your cancer diagnosis is?
You know, it also depends. Yep. So.
Versus a solid tumor versus.
Yep. So it depends on the type of cancer. It depends on the chemotherapeutic agents. We know that the oncology patients are more hypercoagulable. Yeah. So it's a lot of pieces to the puzzle in that.
Yeah.
Yeah. Yep. Great question, though. You know, there are no easy answers anymore. Yep. Hypertension. How about that? 70% of patients who developed upper extremity DVT had a history of hypertension. And then here we are listing all of those. From infection to cancer to osteo, obesity, hypertension, diabetes. Again, that history of DVT. Use of anticoagulants. The number of insertion attempts. Yeah. Catheter tip location. The size of the catheter. Boy, that sure has a role to play in it. Vein selection. The solution. The provider who inserts that line. Major surgery, pregnancy, contraception, hormone replacement therapy, age, gender, smoking, immobility. Yes, ma'am?
When you put number of attempts, would that also mean multiple picks?
Yes. So, yeah. You know, I have been to places where patient had a pick on the left arm, they got a DVT, they pulled it out, they put one in the right arm, got a DVT, pulled it out, they went back to the left arm, and it's like, oh my goodness gracious. When at some point is somebody gonna step up to the plate and say, stop?
Well, don't you think once the endothelial layer is damaged, I mean, that's where your trauma comes out, whether it's from multiple attempts, threading, having trouble threading, jagged catheter, in and out, in and out, in and out, problems with the wire. All of those are related to the skill of the inserter, I think.
Exactly. So you're actually spot on. And if you were to, and I bet if you were to look at some of your data out there and really looked at the skill level of the inserter and the outcomes of the patient, there would be a correlation. Because think about it now, when we were very junior in our PICC careers and first learning it, I mean, we could all probably sit and say, oh my gosh, I can't believe what I have done. But you know, now that we've grown as a vascular access specialist, you know, we've really developed that skill set and that finesse to hopefully avoid some of those things that you said.
This is interesting to me. The studies that I've seen didn't really, the anticoagulant use doesn't really help prevent it, but I've never seen anything that actually contributes it as a risk factor. So if
Yeah.
you're on a blood thinner, you're more likely to get a blood clot with a catheter.
It seems
I would be interested to see more specifically where that
Yep.
information comes from.
yep, I can actually shoot you out all those articles.
I would really like to see it.
I was gonna say, is it because you've had stroke or you're in AFib? You know, why are you on the anticoagulants?
Mm-hmm.
Usually history of DVT.
So all these puzzle pieces are kind of, they're all interrelated. They really are, you know?
They may be on, they
Morbidity on there.
have a history of DVT.
Don't have some of that.
They're on the anticoagulant.
They're a smoker.
And they don't get it regulated right. You know,
Yeah.
I don't know. I'm just curious about it.
Yeah, you know,
One thing I don't say that surprises me is sepsis. A new onset sepsis,
yeah,
because those patients have a higher risk of DVT
Yeah.
than the average.
yeah. And what comes first, the thrombus, the sepsis? So, you know, yeah, so, you know, there's a lot more data coming out now. And I kind of equate this to, I remember, and I'm probably aging myself, but I remember when catheter-related bloodstream infections wasn't a problem. Do you guys remember that? Because we didn't know it was a problem, right? So, you know, no, I remember back when, a long time ago, when catheter-related bloodstream infections wasn't a problem, right? Because we didn't know it was a problem. But when we started realizing, you know, the numbers and the impact, then it was a problem. So I'm kind of thinking now that we're at that same spot with venous thrombosis. Catheter-related venous thrombosis. We're there at the beginning, you know, really gathering that data, putting two and two together, and really more people are doing research and publishing, and we're all becoming much more knowledgeable in that area. Yeah. Yes, ma'am.
I remember when physicians really didn't take upper extremity thrombosis very seriously. They'd look you in the face and say, nobody ever dies of that. You know, I mean, they were serious too. And you'd be like,
At that time, and we worked with the same doctors, but I remember that a lot.
yeah, you remember that. They said nobody ever dies of that. And didn't take it very seriously.
I know.
We didn't take it very seriously what we were doing to those vessels.
Yeah, yeah. So I actually read somewhere that they say in the United States, the cost of DVTs, hospital costs, is between $1 and $2.5 billion, B's and billion dollars every year.
I absolutely love that.
Wow.
I absolutely.
Isn't that a wow number? Yeah. So I really kind of think the light bulb has gone off, and now we are really, we're going, wow, we need to learn more. We need to learn this so we can do better for our patients. Yeah. So the 3 P's of catheter-related thrombosis. We have patient, we have provider, and we have PIP. So patient, some factors. Again, cancer, previous DVT, hypertension. The provider, tip termination location, making sure we get those catheters in the proper spot. Catheter to vein ratio. I am just such a huge advocate of that. I've been talking about that for probably close to 10 years now. Yeah, about how important that catheter to vein ratio is. And did you guys see on the website IV Team that there was actually an article, was it last week or the week before, where there's an article out there now that talks about the catheter to vein ratio.
Would that be Dr. Nathan's?
No, so I'm going to talk about Dr. Naifang's chart in a bit, and I have copies of that if anybody wants it. But this is something different, and I actually printed up one copy, and I'll be happy to give it to you so you guys can make copies and keep it. Yeah. And then, so we have patient, we have provider, and we have PIC. The diameter of the PIC, the number of lumens, anti-thrombogenic technology. So all these play a big part in that puzzle. So going back to nursing school, do you guys all remember Virchow's Triad? Yep. So Virchow's Triad illustrates the inherent risk factors that are present with CVC placement that predispose the patient to DVT. So we have vessel wall injury, we have blood flow stasis, and we have hypercoagulability. Yeah, vessel wall injury. Oh my gosh, how often do we do that? Starting IVs, starting PICs, yeah.
Every time.
Yes, yep, exactly. Blood flow stasis, just by virtue of having that line in that vessel, we are causing a state of stasis, yeah. And then if we throw in those hypercoagulable states, yep. And then here we're just talking about that zone of injury, that needle coming down, going through. And at this point of endothelial injury, again, there is that localized thrombus followed by the depositing of plasma proteins along the catheter wall. And we have an inflammatory response. Yeah. So why is stasis a risk for venous thrombosis? Well, think about this. You know, when we have a vein, it's a long tube, right? And blood moving through that tube. The fastest moving flow is in the center of that tube, the center of that vessel. The slowest moving flow is against the vessel walls. When we put a line in, that line resides in the middle of that vessel where the fastest flow is. And so now we have more points of drag essentially. We've got points of drag against the catheter and against that vessel wall. So just by having that line in there, we are imparting a sense of stasis. And you brought up Dr. Naifang's chart? Yeah, so I actually printed a bunch up just in case. But you know, the first time I saw this, I was actually pretty astounded when I read that, you know, if we put a 4 French catheter in the basilic vein, our flow goes from 15 mils per second down to 7.2. We've only got 48% of our original flow through that vessel. And now think about this when we go into the ICU, right? And what's the first thing that they say? Give me a triple lumen. I mean, that's always the first word out of the critical care nurse's mouth. Okay, and I was guilty of that too. So, but if we were to put in a 6 French catheter in a basilic vessel, our flow is down to 38% of what it was. I think that's just absolutely astounding. Yeah. So I'll just take off my my paper clip, pass that around, and feel free to take one of those. Yeah. So I think those are really interesting numbers from Dr. Naifang. And I've really kind of taken to this heart, and in my travels really tried to get that dialogue going about what we really do as the inserter makes a huge impact on our patients. All righty. So the 4 strongest predictors of DVT in hospitalized patients: prior, cancer, having a PIC in place, bed rest. Another reason to get our patients up and out of bed. It says here thrombosis is the most common PIC-associated complication. And just look here when we talk about catheter thrombosis. the DVT, PE, the mechanical complications, and CLABSI. Yeah, and I actually read an article where they recommended going and ultrasounding patients at the 2-week mark. PIC patients. That would take some man hours, right?
With the volume of participants in the study, I mean,
Yeah, that I can't remember off the top of my head, but if you think about it, you know, yeah, in our free time between 2 and 3 a.m. Yeah. You know, and here are just some of the articles that are talking about PIC-related thrombosis, the year, and you can kind of really see, looking at the far right-hand column, anywhere from low as 2% all the way up to 38%. And really, you know, we've really kind of come to the consensus that the national average for symptomatic catheter-related venous thrombosis is from like 3 to 7.8%. And that's still a really pretty significant number when you look at some of the volume of lines that we're putting in our patients. Also, a reverse taper versus non-taper. This was a randomized control study. Overall thrombosis rate was 71.9. And you know, the difference between reverse taper and taper, 73.4% versus 70.4%.
It doesn't matter.
Yeah.
It essentially doesn't matter.
You know, I think that when we put in lines, there are a lot of pieces of puzzle that we look at when we do our assessment to determine appropriateness for that patient and that catheter. Chest. The reduction of peripherally inserted central catheter-associated DVT. And they talked about the PIC diameter may pose the most modifiable risk for PIC-associated DVT. Smaller devices in larger vessels are less likely to cause PIC-associated DVT. There's also the Grove article out there at the Journal of Interventional Radiology, and they really address the fact that the one factor that I can control as an inserter to help minimize the risk of that upper extremity DVT, PIC-related DVT, is catheter size. So, is there a link between infection and thrombosis? Do you guys think there is? Do you guys agree that that correlation has been made, that link has been made? Yeah, so there's more and more and more stuff being printed out there in the literature. So here is one. There was a post-mortem evaluation of 72 cancer patients with central venous catheters, and it showed a strong correlation between catheter-related sepsis and central venous catheter thrombosis. Fibrin layer was present on all catheters. Catheter-related thrombosis was present in 38% of the cases. Of that 38%, 23% of those had sepsis. So all patients that had sepsis had thrombosis.
Is this, are we talking all central lines, or are we just talking PICs?
No, they were talking all central lines,
Okay.
CVCs.
But that doesn't include ports.
So
Does it include ports, Angela?
I'm trying to remember if, I would have to look at that article again to see if they included ports in there.
Louise is oncology. And,
Yeah, that's the patient population near and dear to my heart, is oncology patients. Yeah, yeah. Let's see. Venous access catheter-related thrombosis in patients with cancer. Patients with cancer are at a high risk for developing venous thromboembolism due to their disease state and treatment factors. The presence of a central venous catheter further increases this risk. Thrombosis and infection are serious complications and more common in patients with cancer. How about this, guys? There's a 47-fold increase in the risk of mortality from VTE in cancer patients with a central venous catheter. I think those numbers are astounding. Yeah. Have you guys seen this? Yeah. I'll never forget the first time I saw it. It was like, wow, what did I do wrong? Yeah, it scared me to death. Yeah. So, known sequela of upper extremity DVT. Pulmonary embolism occurs in approximately 6% of the patients that get an upper extremity DVT. Post-thrombotic syndrome, which consists of all of these. And then also SVC syndrome. Yeah. A lot of things to think about, right? How about Dvt awareness? Each year, as many as 1.2 million Americans suffer from venous thromboembolism, which includes deep vein thrombosis and pulmonary embolism. So do you guys remember maybe 15 years ago or so, they had all these commercials on the telly about DVTs and prevention? Do you guys remember that? Okay, thank you. Because I ask some people, and they're much younger than me, and they look at me with such a blank stare. It's like, I remember that, guys, come on. At least 120,000 deaths per year are directly related to venous thromboembolism. It's among the top 5 causes of death in the United States. Top 5. Yeah. VTE is the leading cause of preventable in-hospital deaths affecting more people annually than highway fatalities, breast cancer, and AIDS combined. 74% of people surveyed have little or no awareness of DVT symptoms, and the cost to treat, just above $9,200. So, you know, when you look at the average, really the cost to treat, $10,000 to $15,000. Big chunk of change, right? Yep. So, what is the impact of this? It interrupts treatment, increases length of stay, increases cost, morbidity, risk of mortality. And think about this, guys. This is just not an adult population. This is not just in the adult population. This affects pediatrics as well. Yeah, affects our little people. These little babies, little kiddos. Yep. So there's more stuff being put out there in the journals, more stuff in the literature about the peds. Any of you guys do peds? Do you? Oh, my hat's off to you. How about, you know, Healthy People 2020, the Surgeon General's call to action? I think that came out, I want to say, boy, it's been a good 2 to 3 years ago since the Surgeon General came out and made that statement about the call to action. So what are we going to do? How are we going to manage this? We're going to talk about the chest clinical practice guidelines. So, chest. Standard 6.1, ultrasound in patients with upper extremity DVT. In patients suspected of having an upper extremity DVT, they suggest initial evaluation with combined modality ultrasound compression with either Doppler or color Doppler over other initial tests, including the highly sensitive D-dimer or venography. So they have a lot of clinical recommendations. In patients with an upper extremity DVT that is associated with a central venous catheter, they suggest that the catheter not be removed if it is functional and there is an ongoing need for the catheter. What do you guys do?
They usually say pull it.
Yeah. You know what I have found really successful with teams that I've worked with? They've actually printed up the chest guidelines and they keep them on their pick cart. And they strike up the dialogue with the physicians and they say, hey, you know, listen, doc, are you aware of these guidelines? And they get that dialogue going. They give them a copy of it. And more often than not, what I'm really seeing is that the physicians are saying, oh, okay, well, let's leave the line in place and treat them. Yeah. I can't tell you how many copies of these I printed up and passed out in my travels. Pardon me?
Where did you get that?
So I actually went online to Google and Googled the CHEST 2012 guidelines.
Louise, I can send it to you.
Yeah, so I really do recommend printing these up and keeping it on your cart or in your office so when this opportunity comes up, you can start striking that dialogue with your providers and educating them. And so there are some other clinical guidelines. In patients with a superficial venous thrombosis who are treated with anticoagulation, they suggest fondaparinux daily over a prophylactic dose of low molecular weight heparin. Yeah? Yes?
Do they say not to put a pick in that arm too?
So we know. Huh?
I opened a can of worms.
Yes, ma'am, you did. You know, it's an ongoing battle, you know. Yeah. It's an ongoing battle. We could talk for a very long time about that. And then here we talk about acute upper extremity DVT that involves the axillary or more proximal vessels. And so they talk about the recommendations there. So there really are quite a few recommendations. And I really, really do recommend that you guys print them up and keep them handy at work. And again, in patients who have an upper extremity DVT that is associated with a central venous catheter that is removed, these are their treatment recommendations. Yeah. And I am actually, honestly, guys, in my travels across the states, seeing more places where they will actually leave the line in and treat if the line is still needed and it's functional. Yeah. And it all comes from you guys, the vascular access specialists, getting that dialogue going. Yes?
We had an interesting situation several years ago where a physician, his spouse had cancer, so she needed a pick. He preferred that interventional radiology put it in. She did develop a thrombus. Interventional radiology, I guess because they were physician to physician, said, we recommend not pulling it because there's an increased chance of getting something else, and because he was a physician, he treated her with anticoagulation at home. They did not pull the line, and she did fine.
Yeah.
But it was because it was physician-to-physician conversation, not general John Q. public patient.
Yeah. We come across that. Yeah, we do. We do. And I think, you know, I think if we can start, when we talk to the providers and try to get that dialogue going and try to really get these clinical practice changes going, you know, present to them, show them that the articles that we're reading, that, you know, we are staying abreast of what's going on out there in regards to vascular access. And, you know, it's an uphill battle. It can be an uphill battle at some places.
Okay, so I have a question.
Yes.
Are you seeing, since you travel a lot, are you seeing any place across the country where they might be just putting patients on a low-dose aspirin? If they have no GI issues or other types of reasons why they could not take an antiplatelet, you know, to decrease the platelet aggregation. Are you seeing that anywhere?
No, I am not seeing that
Years ago,
anywhere.
there was some thinking that a low-dose aspirin in your normal, otherwise healthy patient,
Yeah.
no risk factors, young, that it might be beneficial. But I've, of course, never seen anybody do that in the acute care
Yeah.
setting. But I just wondered if you'd seen that being used.
Yeah, no, I have not seen that anywhere that I've been to. Yeah. Here they're talking about patients with post-thrombotic syndrome that they suggest against the use of compression sleeves. So in an acute upper extremity DVT, not use the compression sleeves, but in patients that do have post-thrombotic syndrome of the arm, they suggest maybe a trial of compression bandages to reduce the symptoms. Yeah. Yeah. So the goal is really prevention, right? We don't want to keep going on and putting in big old catheters and small veins, setting the patient up for this. Our goal is really we want to work on the prevention side. So we want to pick right. We want to assess the need, assess the risk, and assess the tip position. Oh, well, there was a chart here, and it's not coming through. My apologies. But we do need to pre-assess risk factors. We do need to incorporate those risk factors into our decision-making process. And we need to incorporate it into our device selection. Pick right. The catheter does matter, guys. Smallest device in the largest vein possible. 5 French and 6 French catheters have been identified as risk factors for symptomatic DVT. Strong predictor of thrombosis is catheter to vessel size ratio. And I'm curious, do you guys measure vessel size? Thank you. You guys do my heart good. Know your catheter's taper. Consider catheters with anti-thrombogenic technology. Improving our clinical practice. You know, incorporate prediction tools into your practice. Consider vein size in relation to catheter size. And when we measure vessel size, important to always measure without a tourniquet. Make product decisions based on clinical outcomes. Collect your data. Use your data to improve your outcomes. Data, data, data. Collect it, understand it, use it to improve your practice, use it to improve your outcomes. That's what it's all about. Yes.
And I'd like to get kind of the opinion of the group, because I do just that. Look at the vein without the tourniquet and try to size it. What does anybody have any ideas of what effect does dehydration have on the size of those vessels? And really, clinically speaking, how do you manage that? I mean, they need fluids. You can't get an peripheral IV in them. They've called, you know, a vascular access specialist to put a bigger line in. But you know, we're taught that we need to size our catheter to our vessel. So you put the ultrasound on their arm, and they got nothing. You can't see nothing. You know.
Yeah.
You turn the tourniquet on, and then pow! You get this huge giant basilic that pops up. So I'm just throwing that out there for the clinicians that may have wondered that themselves. I mean, what do you do?
So that's
what do you do? Well, I mean, are we going to put a neck, something in their neck for 24 hours, and then then it's going to pop up all their vessels a little bit after they get dehydrated in 24 to 48 hours? Anybody?
So I actually went to a hospital where they struggled with that issue as well. And so what their vascular access nurses did, they would start a peripheral IV with the ultrasound and hydrate the patient before putting the PICC in. That's what they did.
You refuse to put that PICC in if that vessel's too small, Matthew, is what you're supposed to do.
Well, where are the
And then they'll
studies?
send you to somebody else. They'll send them to interventional and they'll do it.
That's exactly right.
That's
That's
what'll
exactly
happen.
right.
Well, you know,
We said we can't find a vein, they'll send them to interventional and they'll do it.
well, then that's
It's not
their
that you can't
decision.
find it, you'll tell them you don't have an appropriate vein to put it in,
That's
and
what
they'll
we
send it
said.
off to interventional. Yeah.
Yeah,
Yeah,
so
they
the
do.
same, and then, you know, so
I mean, your
I don't
guys are
know.
gonna pick in the opposite arm because they got a clot.
You know, I'm a
I
firm believer.
understand your struggle.
Do you understand?
I do understand your struggle.
I would not
do.
walk away from that patient. I mean, sometimes, and everybody that works in acute care, there may be an interventional radiology, or there may be a surgeon. But when you look at alternative sites, the alternative is sending the patient out to the hospital, and that hospital may be a 30 or 40-minute drive. So, would I walk away from a patient without leaving them access? I don't think so. I mean, in my, you know, I know that vessel's small. I know they have an increased risk of a DVT.
Well, the risk versus benefit comes in there.
But to me, in those types of situations, I don't know, I just wanted to kind of throw it out there.
No, I'm really glad you did. So can you see how our jobs are really very difficult? They really are. I mean, our patients are quite ill. And so these are the things that all vascular access specialists, we all struggle with that. And then it's very disheartening when you go down and talk to somebody in interventional radiology and that provider says, I don't care how small the vein is, if they need a pick, I'm going to shove it in there.
Right.
Okay? You know, so it is a battle and there are no easy answers to that. And I think, and this is just me personally saying this, not as, you know, an employee of angiodynamics, but I really think that we as nurses need to step up to the plate, collect the data, and publish it. How does catheter size really play into vessel size? How does that ratio, where is the tipping point on that? And so, you know, I would really like to challenge nurses to step up to the plate, really collect that data and publish.
Is there anybody in this room that is currently collecting their data on upper extremity DVTs and actually looking at that for value? Is there anybody?
Is there anybody here? So I will tell you honestly, there is an account that I've worked with out in California. They were tracking their DVT rates and they were astounded, 12 to 15%.
So is
And-
that ultrasound before placement and after placement?
Yep, so no, so they got their DVT data from the ultrasound department. So they network with the ultrasound department and either on a weekly or a monthly basis, they got a list of all positive upper extremity DVTs. And then they... Symptomatic, yeah. And so, and then what they did is they implemented a new technology, catheter. They continued to collect their data, and what this nurse actually did, she wrote a letter to the CNO of their hospital detailing what they did, what the previous numbers were, what the previous data was, what they did, the changes they implemented, and the outcomes of those changes. And she put in numbers, our vascular access team is saving this hospital close to $800,000 a year in the avoidance cost of symptomatic catheter-related venous thrombosis. And I said, kudos to you, girl. Yeah, yeah. You know, and collecting data, nobody likes to do it, but we have to.
I just don't know that many of our facilities, the systems are really built to collect this type of data.
Yeah, it is difficult.
It sends out, like, we've got a system of 5 hospitals. How many patients go out and come back to a different hospital?
Yeah,
And that data doesn't
Sure.
cross over.
I know.
Right,
A
right.
patient at this hospital versus this hospital.
Yeah,
And they
Yeah.
may not even be in the same system.
Right.
There's a lot of patients that go hospital to hospital,
yeah.
Or
different
you have
systems.
patients that come from out of town.
Yeah.
Yeah.
And they go to their local hospital.
You can't take on the whole world. What you can control is what's
What's
in your
in
building.
my building? That's really all I want.
And I can tell you this, there's a hospital in Evansville, Indiana, where they do track their DVT rates. And between 2 different hospitals and the radiologist. And it's symptomatic. No, not everybody has a PIC, has
Ultrasound prior to.
but it's
and-
symptomatic. I mean, that's all we can realistically do, is really look at the symptomatic, because that's the only ones that we're gonna get a positive on. You know, if they got symptoms, we're gonna order a doctor, then we're gonna know if they do or not. But, and it was interesting that
Is that
whoever
Deaconess?
said this,
Deaconess.
yeah, downtown, or at the Gateway campus. But we would not put the PICC line in because the vein was too small, and then send them to radiology, and the radiology DVT rate was 14%, and ours was 1.4%. You know, so yeah, we avoided the DVTs that we caused, but the patient still needed access.
But the PICC is not the end-all to be-all for every patient, and that's what we have to remember as vascular access specialists.
Exactly.
So
Yeah.
can I ask one more question? Okay, so I heard, you know, and this is just a thought, but we in the past, we put in a lot of more PICCs in patients who were ventilated and sedated and laying up in the ICU with 12 drips. And we would put PICC lines in all those patients. And a lot of those seem to have DVTs. And of course, you know, the big thing is we'll get them up out of bed, get them up out of bed. The bed rest. I wonder about the physical therapy aspect of the range of motion exercise.
Okay.
And where has that piece been lost? To get that blood flow back up into the chest. And, you know, we're focusing on get them in the chair. Okay, well, there they are, hanging out.
Okay,
Intubate,
yeah.
You know, and they're in a chair position.
Yeah.
That does nothing for this.
So I have to tell you, nursing school, range of motion, range of motion, range of motion. It's back to the basics, guys. And thank you very much for bringing that up. I'm a strong advocate of if I'm putting a line in a critical care patient, they're paralyzed and sedated, I'm working with that team. And I talk to the patient's nurse. I say, you need to do range of motion, without a doubt.
Because the stasis that happens.
Yes.
Just paralyzed, you know, I mean, it's incredible. And I wondered if anybody had ever really looked at that from the physical therapy aspect.
Yeah.
Patients that have PICCs, they get this many exercises.
So why not implement a process improvement where those patients in the critical care arenas or those patients with mobility issues, when they get a line placed, range of motion?
They have some type of range of motion.
Why not?
Dedicated set of
Yeah.
range of motion exercises.
Yeah. I mean, I remember what, yeah.
How much exercise or what?
There's no magic number. Yeah. There's nothing out there that we can really,
There's no evidence-based practice that says doing this 15 minutes a day, 4 times a
Yeah.
day will decrease your risk of.
yeah. Yeah, so great questions. You guys are awesome.
Well, normally when they're sedated on a ventilator, they're also tied down.
Yeah, that's true, right?
That right on there.
Yeah.
Well,
I did a study about 20 years ago, and got a community trust fund grant to do it. And it was to look at 25 patients before a PICC and after a PICC with Doppler study. Had
Okay.
a physician in on it with the Doppler study. Every one of the patients, symptomatic or non-symptomatic, had Doppler changes in the vein that had the catheter in it. And then I was so ashamed of myself because I didn't publish it. Because at that time, I didn't feel like I knew enough about publishing. But now there are aids to help you publish. There are a lot of people who will mentor to help you publish.
Oh my gosh, I would love to see you publish that data or repeat that study.
Yeah, I mean, that's a great study, guys. All you gotta do is write one up like that.
Well, they used to have occupational therapists that went around doing this stuff, but they've gotten rid of most of those, so.
I mean, see the great ideas that you guys are coming up with, just sitting here and feeding off of each other. I think this is phenomenal. Yeah.
Yeah, if you even don't do a formal research with IRB and all of that, if you don't want to do that, you can still do a quality
Yeah.
improvement project in your own hospital.
You can, but I would love to see you guys being published so nurses on the East Coast, the West Coast, down south could all see that. So that we as nurses everywhere can say, oh my gosh, look what they did there. Let's think about this. Let's implement that. Yeah, absolutely.
I think it would just be interesting on the people that are on the sedated, paralyzed patient, whatever, with it's laying for days, laying. If you, like I said, if they had a dedicated group of range of motion exercises that were done, whatever amount of times a day, whatever, it doesn't matter, they're asleep, somebody else got to do it for them. And then just to be able to see what happens, because those are technically the patients whose arms blow up with a DVT in our critical care areas. They're the ones who are sedated, that have the stasis, that are not contracting their muscles, that are not moving the blood back up. You know, that's where you see that.
But you don't have to have a PT to do that, do you?
No,
I
you
worked in
don't.
critical
But
care
I-
for years, and we all did our own
Right,
range of
absolutely,
motion
but,
exercises.
yeah, but I don't,
Can't be
I,
nurses do
yeah,
it.
but I don't think that,
We
that
don't
don't.
have enough staff.
I was like, they don't have enough time. They
And
don't
you
have
think
enough time to
have the
get meds.
same exercises for each patient. You know, whatever it is, you wanna have the same amount, the same number of reps.
Yeah, you have to
Have pairs. Oh, well, whatever.
No, I think these are great ideas, guys. You know, thought process are being sparked. I love it.